Assalamu alaikum. I'm Dr. Tariq. So today we'll discuss the topic of DVT in puerperium. This is the talk station in which the history was given the 7th postnatal day. Patient presented with unilateral leg pain and fever. So the questions asked by the examiner, the risk factors, differential diagnosis, examinations, what is hope and sign, how will you manage this case, which anticoagulants you will give, what are the other types of anticoagulants, and the dose of unfractionated heparin or conventional heparin. So a patient that is post-delivery with 7th postnatal day having unilateral leg swelling. So first of all, we should have a differential diagnosis in our mind that if a patient presented with a unilateral leg swelling, we should start asking the history points by keeping in mind the differential diagnosis that it could be a DVT, deep vein thrombosis, it could be cellulitis, it could be ruptured Baker cyst, it could be varicose veins, or it could be a thrombophlebitis. So with all these differential diagnosis, we will ask the history questions one by one. Like we'll start from asking the questions that how symptoms started, like it's a sudden in onset or gradual or progressive in nature. First started with fever or first started with the pain. So it's if patient says that it started with the pain, so from where the pain started, like lying in a position or sitting position or walking, so what does this trigger the pains? Second, we'll take the history by asking the question that any direct injury to that leg, any trauma, any bite, like fly bite, any bite by any thing that can cause cellulitis. In the same time, if we rule out that this is a new in onset or it's a first time this swelling or happened, or this happened before in the previous pregnancies also. Because if it's a recurrent or frequent DVTs happening postnatally, then it means that this is the risk factor associated with the pregnancy that can lead to clotting or thrombosis. Plus, in the meanwhile, when all the questions are leading towards the DVT, then we should screen out the risk factors by asking questions like, in this delivery, it was a simple delivery, like any history of prolonged labor, cesarean, hospitalized admissions, ICU stay, bed bounce time, how much she remained, like sometimes patient remained in the postnatal period 3-4 days in the ICU without any mobility, or patient having history of any bleeding, and patient was started on tranexamic acid and she was taking for prolonged 7 days, and that can lead to triggers to clot. In the meanwhile, family history is also important. Plus, the same any clot history or DVT history in the same patients happened previously in lost pregnancies or any age group, that is also a risk factor. In this is like another important questions that should be asked, that is this swelling or the pain causing any problems in the mobility, or this issue is making impact on the patient's daily life. Why this question is very important? Because patients can't walk, patients can't lie down, can't sleep because of pain or in this swelling, she can't walk. So it means that this is impacting the patient's daily life. So sending the patients home without asking or addressing this issue can put a bad impression on the examiners. So we should ask this questions to address, that is this causing any issue with the patient's daily life. If the patient is sitting and examiner asks the candidate to ask the questions directly from the patient, then you should ask your questions in Urdu or in the language that patient is able to understand, Punjabi, Urdu, Pashto, whatever the language it is. Directly you can ask the questions by simple language, like we can say that is there any previous history of clot, और कोई खून जमने की कोई किसी टांग में आपका खून जमा है, कोई फेफड़ों में कभी खून जमा है, कभी आपने प्रीवियसली पहले कोई खून पतला करने वाली दवाई 3 से 6 महीने के लिए ली है, क्या आपकी बहन को, आपकी माँ को इस तरह का कोई उनके लेग्स में या उनके फेफड़ों में कोई खून तो नहीं जमा था, खून का लौथा तो नहीं जमा जिसके लिए उनको खून पतला करने वाली दवाइयाँ लेनी पड़ी. These all are leading to the family history or plus previous history of the risk factors. So when you had took the history and made a differential diagnosis that it's all going towards the DVT, then we'll go for the examination. So in examination, we'll check the local tenderness, temperature, size of the cough by comparing the other leg, and we'll do the Hoffman's test. Like we'll ask the patients to stretch the leg, and we'll perform the Hoffman's test. If it's causing tenderness in the cough area, it means there is probability, but it's not the diagnostic 100%. Its sensitivity and specificity is very low because it can positive in any injury, any Baker cyst, any condition that can leads to swelling of the cough or lower leg. It can be positive. Plus in the lab we do the D-dimers, but again it's a negative predictive value. Like if the D-dimers are positive, it doesn't mean that there is positive DVT. If there is a negative D-dimers, it means that there could be no DVT, but positive, it means there is a probability of the DVT, but it's not diagnostic. So for the diagnosis purpose, we go for the duplex scan. If the duplex scan is positive, it means that there is the DVT, and that is diagnostic test. Gold standard test is for DVT is venography, but usually we don't go for the venography. For the gold standard, we do the duplex, that is a diagnostic test for the DVT. So already we discussed the differential diagnosis. So if we confirm the diagnosis with the duplex scan, then we'll go for the management. In the management, it depends upon the severity of the condition. Like if the patient is having a active pain, swelling legs, she's unable to walk, she's unable to bear this pain, then obviously we'll admit the patient, we'll take the consultation from vascular team or intervention radiologist. If patients say that okay, I am capable of walking, but there is pain, but there is no ongoing ischemia, then we'll take the history of any bleeding tendency, like patient is having no active bleeding, no active GI bleed. Then we can discuss the anticoagulation options with the patient. If patient is having on the feed, like feeding the baby by herself, it means that that any medication that we can give, it can go into the baby also. So we'll keep in mind that we should avoid that medications. So the safe medications that are used in the lactating mothers are low molecular weight heparin and unfractionated heparin plus oral warfarin. So if patient, we'll ask the patient that if she is able to take the injections, then our priority will be low molecular weight heparin, that we call it Enox Calaxane 1 mg per kg BD dose. If patient is unable to take medication because of social issues, financial issues, or then we'll give her option oral warfarin. Oral warfarin is only had a side effect that it is cost effective, but we have to go for the INR check weekly. So if patient can't manage this, then again putting the patients on warfarin without monitoring is risky. Third option is unfractionated heparin, but unfractionated heparin again that we can give loading dose and then infusion. It's again needs to hospitalize the patient because subcut dose of unfractionated heparin is not correct in a way that we can give the DVT prophylaxis dose, but for the therapeutic dose we need to give the infusion. The last option that we have nowadays, that oral anticoagulants in the form of DOAC, direct oral anticoagulants like apixaban and evrexaban. We usually can offer these medications to any adult patient with the DVT who does not have any capability of tendency of bleeding. We offer these medications, but again with the lactating mothers it's contraindicated, so we avoid these medications in the lactating phase. Again it's they're a little bit a high level question, but maybe some examiner can ask you this question, that okay, patient is having a DVT, we need to anticoagulate, but patient having a bleeding and we cannot put the patient on anticoagulation, then what could be your next option? Then your answer should be we'll take the expert opinion from the hematologist, clinical hematologist, intervention radiologist, because that patient needs inferior vena cava filter for short time when there is a tendency to bleed. When the bleeding tendency, its risk factors ruled out, then we can again resume our old oral anticoagulations. So these all are the managements, differential diagnosis, and history of the DVT patients. Thank you.